world. Again, some of your visual disturbances, perceptions, and of course the hippocampus, learning and memory, as we mentioned, okay? Now, there are some of your scans. This is one of your SPECT scans. They do notice in brain function that when you look at the cooler areas versus the average areas, that the schizophrenic brain changes over time. So perhaps you have some earlier deficits up here. It doesn't look too bad, but here it really does look bad. So we know that the brain is changing in schizophrenic patients. So maybe that's why drugs, even though in long-term treatment, they've got a hard bar to reach anyway to treat those symptoms. But now you think of the brain getting worse in the schizophrenic patient. Can you imagine 10, 20, 30 years of a patient with this disease? And the drug effects seem to, of course, wear off in this aspect. So that, again, becomes a challenge in therapy. Okay, so now, turning from what we see in the brain to now your more neurotransmitter system. As I mentioned, dopamine was one of the main neurotransmitters based upon the early amphetamine models. So what they have derived using of dopamine in the effective treatment of this disorder is in this particular fold. If a person has, these patients have what they call a hyperdopaminergic activity in the mesolimbic system. That's why you got to understand the different parts of the brain involved. You have the positive symptoms, okay? Hyperdopaminergic activity in the mesolimbic system. If you have a hypodopaminergic activity in mesocortical, you have the negative symptoms. So you have two parts of the brain in thought processes that are involved, mesolimbic and mesocortical. Mesocortical for the negative, mesolimbic for the positive. Okay? So a very interesting aspect in this. Now, there are other non-dopamine neurotransmitter systems involved. Some people think it's glutamate and some classes of glutamate receptors. We showed you that, say, in the seizure model. But as of yet, there's no real glutamate compound that we have for schizophrenia. Not that they haven't worked on it. They've all failed in clinical trials. Proof of the pudding's in the clinical trial of a schizophrenic patient. Okay? And so, as I mentioned, positive symptoms, mesolimbic, mesocortical, negative, nigrostriatal. Striatal is you get your side effects like extrapyramidal movement disorders, tardive dyskinesia. Talk much more about that subsequent sessions. And then your tubular endofundibular pathway. That is your endocrine system, like your prolactin. And I know you've had prolactin effects. From what module? Endocrine. Endocrine module. I know you talked about prolactin and endocrine function, right? Well, this is where else is part of the brain. Now, can anybody say tubular infundibular 5 times in a row without flubbing it up? It takes practice, believe me. I still flub it up, okay? So, but keep that. This is the one for endocrine, okay? And again, this is a nice table that puts it out there. Your dopamine track, you have 4 of them, where it originates, the innervation, function in schizophrenia, higher level function, like your thought process, lower functioning, obviously also in mesocortical when you have that particular impact. And again, you can see here, if you have a drug that is a dopamine agonist, you have release of psychosis, or if it's an effect, a movement disorder, or an endocrine effect. Okay, so it becomes very challenging for the drugs when you balance risk versus side effect all the time. And these are just not the only side effects, as we'll see more on Friday. So when we look at this, and I like this particular picture, when you think about that, these are the projections, very simple. You see that when you look at the implications here, when you have an antipsychotic drug, really the implications is to reduce the positive symptoms. That's what initially antipsychotic drugs were designed to do, okay, in the olden days. In fact, chlorpromazine was the prototype antipsychotic drug, and I'll talk about the structure and pharmacology of it. But they, like all great things in science, they found it by accident. When they found chlorpromazine, they were looking for a better antihistamine. Now, it has a lot of antihistaminic effect, but they were looking at it to treat allergies. There you go. And they found out, gee, they gave it to a person who's psychotic, they got better. And so that started the realm of psychopharmacology in the early 60s. So you just never know. And just to keep thinking about this, how far we've come along in society and culture. What did we do with schizophrenic and psychotic patients before antipsychotic drugs in the 60s? Huh? Psych ward, straitjacket? Yep, exactly. Down at the San Antonio State Hospital, again, you heard that's my early part of my career. I actually went down to the dungeons and the caverns on the ground. There were chains on the walls. Yeah, think about that one. Just go, ooh. So those are things you think about and how you treat those patients. Okay. Mesocortical, again, just to give you another where we are, again, with those negative symptoms. We have drugs now for the atypicals that really address that, but you can see it's really linked also to the cognitive symptoms a little bit more, and you can see that's really linked into the frontal cortex of your brain, okay? And then, of course, the nigrostriatal pathway. So we really know a lot about these dopamine tracts and their effects on the brain in this aspect. So, and of course, you know, what the drugs do to them. And of course, the tubular infundibular pathway down to the pituitary gland. Bring back an old memory cell. Okay, so that's the dopamine system. So let's try this question. Hypodopaminergic activity, mesocortical, can lead to negative symptoms. Okay, we're pretty good. Stop at 40. That is correct. A is true in this aspect. Okay. So let's talk about a couple of other neurotransmitter systems. Serotonin is also very prominent. We'll see that a lot of antipsychotic drugs, especially the atypical agents, have a pretty pronounced pharmacologic effect on serotonin. I know Dr. Pong and Emmett will talk about that. But it's interesting to see that where present, both dopamine and serotonin almost have an interrelationship. I don't think we really quite know what that is yet, but we know it's there. When we look at an antipsychotic drug today, atypical especially, they can't have all dopamine without serotonin. It will not be a very good drug. You've got to have some of both in this. If you've got a drug that's predominantly serotonin, it may work. To give you an example, that Parkinson's drug, right, that we talked about. It's primarily serotonergic with a tiny bit of dopamine. I bet you it would work for schizophrenia, but the problem is the market for schizophrenia is already saturated with a large number of drugs. So they were going for a niche market. So those are things you have to think about in this aspect, because we know that quetiapine in low doses works for Parkinson's-induced psychosis. Okay? So those are things to think about. Okay? So you do need some serotonergic effect. So really, as I mentioned, all antipsychotic drugs have both serotonin and dopamine binding affinity at some level. And then the glutamate system, again, may be involved. We just don't have that. Ketamine model, some people have explored that, but ketamine now is actually kind of shifted because they know that that could be impactful for cognition. They're actually looking at ketamine infusions for treatment of refractory depression. And so Dr. Cohen will be talking more about that too right now. And by the way, but they know that ketamine does also cause a little bit of disinhibition. Okay, anybody know? Anybody have a ketamine? Nobody have ketamine? Nobody wants to admit to ketamine? Not if you have refractory depression, but you know, for uses otherwise. I can tell you my son had it when he had first year. This is a phone call you don't want to get as a parent. He was a freshman at UGA like 6 years ago. All right, we dropped him off at college. We said goodbye to him. Mom hugs him and cries on the way back home to Fort Worth. 2 weeks we get a call later, 10 o'clock at night, on the cell phone. Hello, Mr. and Mrs. Jan. Yes, this is so and so. I'm Trevor's friend calling on his phone. Yes, 10 o'clock at night. Just want to let you know Trevor's in the hospital. Oh, he has a collapsed lung. Oh, so we finally call him. And he goes, what, do you want us to come out there? No. Yes. We go out there, fly out there. And so I talked to the nurse, and she said, well, we had to stick a tube in his chest to reinflate his lung. I said, what'd you give him? She goes, ketamine? Really? And she goes, you'd be surprised what ketamine did to him. I said, what's that? He said some swear words to me I did not know was in the English language. From my son's mouth? So it really caused a little bit of disinhibition, but it's a wonderful anesthetic, also used in the veterinary world, that kind of thing, but they're now using it for lots of other things. So it's interesting how ketamine is coming back in this aspect. So there you are. Follow-up story is that when you're 18, they're going to do surgery, and the chest surgeon comes in here, tells me what we're going to do, no problem, and then signs and he gives it to my son to sign the informed consent for surgery. So my wife is about to grab it, right, to sign it, and the nurse turns and looks at her and says, we don't need you to sign it. I thought she was going to kill the nurse. You're saying that to my son? Those are the things to think about. Anyway, there you are. Okay. We don't know much about the inflammatory system. We just know it's there in that aspect. We know that there's an overexpression of interleukin and all that sort of thing that seems to be occurring in patients with schizophrenia. So far, none of the agents have ever tried to modulate the system ever works. Believe it or not, they tried to infuse interleukin in like IL-12 in a schizophrenic patient. Doesn't work. So, okay, fine. So right now we don't have any of those agents, but the hypothesis is there. The last one, insulin resistance and metabolic disturbances. Well, we're going to see in the next from Friday where antipsychotic drugs cause a lot of metabolic problems, especially the atypical ones. But we also know patients with schizophrenia also get diabetes, so you got that complication. And then finally, we talked about the days before we had antipsychotic drugs. We said talking about to treat them. We talked about the straitjacket and the chains. Well, guess what they did in those olden days besides electroshock therapy, but that's one way to do it. They infused insulin to the psychotic patient to make them into a comatose state so they wouldn't be psychotic. Yeah, so if they're in coma, they can't be psychotic. Yeah, your eyebrows go up. They did that, yes. Now, then they always gave them glucose to bring them back up. But just think what happened when they gave them a little bit too much insulin. Sometimes they didn't wake up. But then they weren't psychotic anymore. So it was like, wow. So they call that insulin coma therapy in the 50s. And they also did lobotomies, by the way. They stuck little needles in there and they scrambled your prefrontal cortex. You heard about that, right? Yeah, it's a little needle, goes in between the eyeball right there, and they just scramble and done. That sort of thing. And it's not done. Yeah, in the old days, one of the Kennedy kids had it. Yeah, sure, absolutely. So anyway. Okay. I think do I have one more? I think I have one more question. Let's try it. Which two dopamine tracks are associated with the relief of psychosis? And then you'll be ready for Dr. Palm. Emmett. Where's Dr. Emmett? Is he coming down? He should be in here. He's probably right out by the door, right? No, I don't see him. So before we get into drug therapy, we did talk about some of the older ones already. Lobotomy, electroshock, insulin coma. All that almost sounds medieval, doesn't it? Yeah. Okay, let's see what we got. Yes. B is the correct answer, is mesolimbic, mesocortical. Tubular and fundibular is what? Endocrine system. And nigrostriatal is what?